So the case for today is the first case which we'll be discussing during this particular session, and it is a patient who has abdominal symptom. So 60-year-old homemaker presented with, I think here you need to mention the patient name, age, gender, occupation of the individual, the place where the patient is coming from. I think that you will be knowing as a basic thing which you should do. Complaints of yellowish discoloration of the urine for the past 1 month and abdominal pain for the past 1 month. Okay. So now I'll put a question to Vignesh.
Yes,
Now,
sir.
should you include informant in this case? Vignesh, should you include informant in this case?
Sir, no, sir, because patient is
So Vignesh
conscious.
has prepared the case, so I just wanted to know whether.
Sir,
Vignesh, you have to type. I'm not able to. You need to type.
yes, sir.
Okay. No, informant. See, I'll give you the reply. Somewhere in the history you have mentioned that the relative noticed yellowish discoloration for 1 week. See, whenever you are bringing in a relative's input in the history of presenting illness, you have to include them in the informant also.
Okay, sir.
Or you can, because the patient has actually, because the history of presenting illness, you have actually written it. When I go down, you will know. So since the patient is actually telling that there is jaundice for 1 month, yellow discoloration 1 month, I think you can leave the attender history. Attender history can be left.
Okay, sir.
Okay.
Okay, sir.
So whenever you are including input from the relative, ensure that you include them in the informant also. In this case, I would prefer, since the patient himself is telling for 1 month, 1 week yellowish discoloration. Okay, patient didn't know the yellowish discoloration. Am I right? That is the reason you have included. Am I right, Vignesh?
Yes, sir. Yes, sir. Patient didn't know that.
I was. Is that right?
Yes, sir. Yes, sir.
So then it's kind. Then in that case, you have to write it as. Then you have to write it as informant is patient and his relative. Whatever relative you have got it, you should include it. Okay, so remember that. So I'll go ahead in the history of presenting illness. So history of yellowish discoloration of urine for the last 1 month. So you have to tell the duration first. Okay. History of yellow. So I'll just correct it then and then. History of yellowish discoloration of the urine.
Okay, sir.
For 1 month. Okay.
Okay, sir.
So gradual in onset and progressive. So I'm just deleting the remaining. Gradual in onset. Progressive. Then history of attender noticing yellowish discoloration of the eye for the past 1 week. So this closes the description of jaundice. Then
Yes,
you have written history of clay colored stools. So no history of clay colored stools. Pruritus, intake of hepatotoxic drugs. Okay. So this I think you can include it, or you can include it at a later point of time. At the end you can include it. Okay. Now what is that you asked? Hepatotoxic drug, Vignesh? Because in the history of presenting illness, you have to tell common drug which the patient accessible. So what are the hepatotoxic drug? You have to bring it in, or you want to bring it somewhere at a later point of time. Paracetamol. Okay. So I will recommend here no history of clay colored stool. Pruritus. Will stick only to the jaundice. We'll take the hepatotoxic drug at a later point of time. So paracetamol again in healthy individuals, I'm not sure whether a therapeutic dose creates a problem. So this will take it at later point of time. Maybe we can even include it in the treatment history, or you can put it down the list. So this I'll take it out now. So we'll just, whether you have elaborated the question for jaundice. whether that is correct. You have reasonably corrected it. So clay colored stools and pruritus. This should be okay. Fine. Next, you have elaborated history of abdominal pain. See, again, you have to ensure the duration is added here. To save time, I am correcting whatever is there. So abdominal pain is also for 1 month. For 1 month. Okay. Over the right hypochondrium. Any alternative word you can use, Vignesh? We have written right hypochondrium. In the history of present illness, is it correct to mention that or some other alternative should be written there? What is the preferred phrase or word there? Can you use a word right upper abdomen? Very good. So don't use technical words there because we are still in the patient description. So you will write right upper abdomen. Okay, so I think the pain is more in the upper right, and so upper abdomen more in the central, and so here you will correct it as, don't use right hypochondrium, don't use epigastric. Okay, you put it as right upper abdomen, right side and central part of the upper abdomen. Okay. So next you have elaborated. First you have told the duration, then you have told the site. Okay. So these are all basic undergraduate things, but ensure that you don't make a mistake on these basics. So you have elaborated the duration, you elaborated the site, then you have elaborated the character, dull aching. Okay. Now one description you have missed. Can you tell what it is? We'll give the option to Vignesh first, then others can come in. One description should be there after dullness. Something should be added here. What should be added? After the character, should anything be added? Others can also give your inputs. What should be added after the character? Onset. Okay. Intermittent or continuous? Okay. Now, here, I forgot to correct one more basic thing. So I'll just correct it now. History of abdominal pain for 1 month. What? How was the onset and progression? Vignesh, how was the onset and progression? If you remember, you tell. Otherwise, I'll just.
Sir, onset was
How was the onset and duration? If you remember, you tell. Otherwise, I will put it as a question. Onset was gradual, increasing pain day by day. So it is onset, gradual, and onset progressive. So we will finish it first. So abdominal pain for 1 month. So gradual onset and progressive over the upper abdomen, right and central. Okay. Dull aching. You have to tell whether it is continuous or intermittent. Okay, I think one of you think Anand told was it continuous or intermittent? Was it a persistent dull aching pain or was it a intermittent pain? Vignesh, if you remember, you can enter it. Was it a intermittent pain or a continuous pain? If you don't remember, I'll just put it a question and we'll just move on. Not sure. Okay. So remember that. So here after the dull aching, you have to tell whether it is intermittent or persistent or continuous. Whichever word you want, you can tell. Okay. Now, not radiating, not radiating, no diurnal variation, no aggravating factors, relieved with medicine. Now, Vignesh, why you wanted to ask about diurnal variation? Abdominal pain and diurnal variation. What diagnosis was in your mind? You have put diurnal variation. So what diagnosis was there in your mind? Because you are telling a right upper abdomen and central. If it is peptic ulcer, okay. So that's okay. So in that case, you want to, you can tell it as nocturnal. That's all. You are looking into nocturnal. Okay. So you can, so that's the implication. It's okay. You can mention it. It's not a problem. But you have to be clear about what is there in your mind. So no aggravating factors. Relieved with medication means what medication? Relieved with medication means what medication? What was the medication which relieved the pain? Not sure of medication. Okay, fine. So if you mention the medication, you have to tell what it is. Okay, be clear in that. Now, this is the correct way of elaborating. So I'll just go back in the correction of elaboration. See, always remember at a PG level, never do mistakes in the basic content of the case sheet. Like elaborating a common symptom. Abdominal pain is a common symptom which you repeatedly teach for the undergraduates. To ensure that you describe it properly, there should be no scope for error there. So abdominal pain for 1 month, gradual in onset, progressive, over the upper abdomen, more on the right and central. Dull aching, we have to check whether it is intermittent or persistent. Not radiating, no diurnal variation, all the other things are fine. You have to mention what is the type of medication there. Okay. So then you have told history of loss of weight 94 kg to 84 kg over 6 months associated with loss of appetite. So when you document it, just be clear in one thing, whether the patient really measured and you told, and was it also appreciated by the relatives. So when you put a number, just confirm whether the patient has actually measured and verified. Okay. No history of abdominal distension, no history of vomiting, melena, no history of fever, no history of native medication, altered sleep pattern, history of fatigue. Okay, fine. Now, can you quickly tell the relevance of the symptom? So, what was there in your mind when you asked about abdominal distension? You can type all together, Vignesh. You can type all together. What was there in your mind when you wrote abdominal distension? What were there in your mind when you wrote melena, fever, altered sleep pattern? Those 4 things. So that is all you have elaborated in the history of presenting illness. What diagnosis was there in your mind? Abdominal distension or ascites, okay, fine. Then melena, be quick in the answer because these are basic things only. Just I'm just asking the UG level question. I'm not for any. Okay, it could be occult cirrhosis. It could be an occult cirrhosis. It could be a portal hypertension which is unmasking suddenly. Yes, fever, fever. Now, why you are thinking about SBP? Fever, why? See, when there is no abdominal distension, why SBP should be the reason you ask fever? There should be some other reason for fever. Fever is not for definitely SBP. There is no abdominal distension in the history. So you don't suspect ascites based on history. And Anand has replied, viral hepatitis. Vignesh, again, acute or chronic. Which you want to choose? Is it acute or chronic? Is it acute or chronic? Just 1 month of jaundice. What is that you are interested in? Acute. Okay, so that's what you have to have. So acute is the priority. See, chronic hepatitis, most of the time it presents without fever. Most of the times. Okay. Unresolving acute hepatitis, that can present with the duration of 4 weeks. Okay. Altered sleep pattern. Altered sleep pattern. Altered sleep pattern. Hepatic encephalopathy. Okay. Now, can you get hepatic encephalopathy without ascites? Acute onset jaundice. Since it's only 4 weeks, I'm telling it's acute onset jaundice. So acute onset, without abdominal distension. So I assume ascites is not there. Can you get hepatic encephalopathy? Yes, you can get. Okay. So acute fulminant liver failure, especially when it onset, at the onset, fulminant hepatic failure at the onset, a sort of a subacute to delayed type. Hyperacute will be very, very quick after the onset of jaundice. So when the hepatic encephalopathy sets in, you can have altered sleep pattern. Okay. So anything else we have left out here? Anything else we have left out here in the history of presenting illness? Anything else we have left out in the history of presenting illness which is targeting the symptom? Jaundice for 1 month, abdominal pain for 1 month. Have we failed to mention anything which is relevant to the patient in the history of presenting illness? Others can also try. Now it's open for discussion. So others can also bring in anything else you want to ask which is relevant. As I told you, this is a semi-long case. You can write only 1 page in the history. So have you accommodated all the necessary thing, or is anything else left out? Others can also reply. Anything else left out? At least reply yes or no. Diarrhea. Aditya has mentioned diarrhea. Aditya, why diarrhea? Why you want to ask about diarrhea? Acute viral hepatitis. Okay. Okay, I agree, but it's not a very diagnostic thing. It starts with GI symptoms. Good. So many acute viral hepatitis can start with a bowel disturbance. I agree. Anything else? Anything else? I'll give you a clue. Patient is a hypothyroid. He has documented. I think pruritus he has mentioned. Aravind, he has mentioned pruritus. He has mentioned no history of clay-colored stool. Pruritus he has mentioned. Vishnu has entered urine output. Justify. Why urine output? I have given you a clue. Priya is telling skin discoloration. History of rash. Can you justify? Priya and Aditya? Autoimmune hepatitis. Good. So, is the patient at risk for autoimmune hepatitis? Yes. So, what else you can document in the history when the patient is? So, can you just tell me who are at risk for autoimmune hepatitis? Who all at risk for autoimmune hepatitis? Generally, which population? Middle-aged female. Okay. Then middle-aged female. Anything else? Any other risk for autoimmune hepatitis? Hypothyroid. Agreed. Then what else? What other diseases? Family history. Okay, to some extent. Diabetic. No, diabetic people are not at risk for autoimmune. At least not in the top 6. Not in the top 6. Other autoimmune diseases. Which one? Aditya has replied other autoimmune diseases. Okay, he has also given one more answer. Aditya, vitiligo. I agree. Vitiligo has to be looked for. But before that, we'll finish this question. Who is at risk? Who is at risk for autoimmune hepatitis? One, hypothyroid. Who else? Now we are in the rheumatoid arthritis. See, remember connective tissue disease. So autoimmune disease can occur in people who have hypothyroidism. So it can be associated with certain additional skin diseases like vitiligo. Vitiligo is one condition you have to remember. Any other skin condition, actually there is a big list of skin conditions which is related to autoimmune hepatitis. What are the skin conditions? It's quite a big list. At least you should be able to come out. Very good. Psoriasis. So we have finished 2. Vitiligo 1. Psoriasis 2. Then anything else? Okay, I'll tell you the third one. Vitiligo, psoriasis, 2 common things. Remember lichen planus also. Remember lichen planus also. Okay. Scabies, I am not sure. I don't think to have read about scabies. These 3 things you remember: vitiligo, psoriasis, lichen planus. 3 things quite very frequent. So any kind of a skin thing. So autoimmune hepatitis, what are the skin symptoms you may get? What are the skin symptoms you may get? What are the skin symptoms you may get? Pruritus is part of liver function abnormality. What I'm asking is the extrahepatic manifestation of autoimmune hepatitis. Photosensitive rash. Okay, not necessarily photosensitive. Rash, I agree. Which part of the body? Rash in which part of the body? Rash is correct answer. Face. Okay, it's books to books. There are some differences, but most books agree that it is face, trunk, upper arm. Okay, so face, trunk, the upper part. Face, trunk, and the upper arm. So this is the place where you may get the rash. So skin symptoms are relevant here because since you are telling hypothyroid, see at a PG level, always remember that when you are writing a semi-long case, ensure that you bring in the differential diagnosis history there. In this case, skin is actually relevant. Okay. Anyway, one more I will add here. See, jaundice, abdominal pain for 1 month. Will I think about any infection outside hepatotrophic infection, outside hepatitis? Hepatitis A or hepatitis B? Will I think any other hepatic infections? CMV, good. Anything else? EBV, okay. Anything else? Leishmania is not endemic, so we don't think about leishmania straight away in the absence of endemicity. I agree it can occur, I agree. HIV presenting with clinical jaundice, usually it is due to CMV or some other viral infection, not HIV per se. Since you have already told CMV and EBV, I'm not taking up HIV because it's a secondary involved. 1 month, abdominal pain and without fever, very difficult to bring in scrub typhus, malaria and all. Again, jaundice for 1 month in scrub rickettsial infection is quite uncommon. And you don't get abdominal pain that frequent. Liver abscess, abdominal pain, yellowish discoloration. To some extent, I agree, but again, only pyogenic liver abscess presents with jaundice, amoebic, relatively less common. Anything else? Okay. Anyway, I'll just tell the answer so that we move ahead. See, also remember granulomatous hepatitis. Don't forget granulomatous hepatitis. So granulomatous hepatitis is a great mimicker of hepatitis, chronic hepatitis. We have seen quite a few. I think you would have also seen people coming with a granulomatous pattern. They will have other involvement also. So though fever is not there, liver involvement in tuberculosis is quite well known in the absence of fever. Okay, so why I am asking is that history is suggestive of lymphadenopathy in the form of any swelling in the neck, at least any swelling in the neck You can add there because to some extent sarcoid also will come there. The acute presentation of sarcoid. So EBV may have history of throat, sore throat, cervical lymphadenopathy which has resolved. CMV also may have mononucleosis like symptoms to begin with. Okay, so remember, so symptoms suggestive of upper respiratory tract infection, symptoms suggestive of enlargement of the lymph node, symptoms suggestive of skin involvement. So this has to be added in the history of presenting. Is it clear how I have elaborated what should be asked more in this case? Because autoimmune hepatitis, many other differential diagnoses will come into the picture. Okay. So try to be more comprehensive. You are talking at a postgraduate level. So you need to have a more broad kind of a diagnosis. So this is the correction I would like to suggest here. So I'll just type in the history here. So the relevant thing here will be add history of upper respiratory symptoms. So this has to be added. Then you need to add about any neck swelling which has actually resolved. That will give you a very good clue. For example, the patient tell, yes, I had sore throat and neck swelling which resolved the first 1 or 2 weeks. That will give you a clue to a sort of a mononucleosis like kind of a syndrome. Okay. Then, okay, so upper respiratory symptom. Then you will add about the swelling, any rash. So that becomes relevant. Okay. Now, if it is going to be a sarcoid, if you are looking into a acute presentation of sarcoid, what else you can add here? Any other system can be involved in sarcoid. Usually in aggressive sarcoid, cough, very good. So respiration, don't forget about, so cough. Okay. Okay, facial palsy, I agree, but generally the lung, when the rapid thing, so just I'm added cough, I leave it as optional. So some people may think you are going too much outside the way. So you can probably restrict with these things, respiratory symptoms, neck swelling. So remember, skin should not be missed. Okay. So we'll go with that. So I'll give you a green color there so that you are able to get it. Okay. So this is how you have to elaborate the history of presenting illness. So now going into the past history. History of diabetes for the past 2 years on oral hypoglycemic agent. See, avoid brand names here. Don't tell Thyronorm, tell Thyroxine. Okay, so don't use brand names there. History of surgery. Okay, so you just tell the patient underwent tubectomy. Patient underwent tubectomy. So when was the tubectomy? Elaborate that. No history of hypertension, bronchial asthma, seizures. History of blood transfusion, tattooing. No history of jaundice in the past. I think mostly you have brought out thing. Okay. Now, quickly going into that. See, what are all the drugs which taken on a chronic basis can cause jaundice? What are the drugs which taken on a chronic basis other than anti-tuberculous drugs? Other than anti-tuberculous drugs. What are the other drugs which can, okay, I agree. Estrogens, good. Phenytoin, good. Nitrofurantoin, relatively less common, but I agree it can occur. Allopurinol, relatively less. Erythromycin, we don't take it for a long time. Methotrexate, I agree. Any other disease modifying agent? Any other disease modifying agent? Anabolic steroids, agree. Leflunomide, yes. Mycophytal morphital, very good. Don't forget MMF. MMF can cause a very close mimic of chronic hepatitis in a small proportion of patients. Anything else? One more drug, common disease modifying agent, which can affect the liver. HCQ is quite rare. HCQ is affecting the liver is quite rare. One more drug. Okay, azothioprine. Azothioprine can also cause. Sulfasalazine again quite rare. Sulfasalazine, I agree, all can cause, but I am talking about percentage which is close to maybe at least 2.5%. Okay. So just remember those drugs because they may ask you about those kind of a drug. Okay. Fine. Now, fine. Past history is okay. So any other past history we should have involved here. Okay. So we will go out with the personal history. So I think personal history you have brought out the is not a smoker, not a alcoholic. Now I have to get back to Vignesh. Now what is the now can you justify why you have thought hepatocellular carcinoma as the first differential diagnosis or CA head of the pancreas, NASH, hepatitis? Can you justify your order, DD history order, Vignesh? Can you justify your history order? HCC because loss of weight. Can loss of weight occur in CMV? Can loss of weight occur in tuberculosis? Can it occur in autoimmune hepatitis? See, that should not be justification. See, okay, can you tell one reason? Others can try it. Can you tell one reason why you should not put HCC or CA head of the pancreas as the first differential diagnosis? Others can try it. Why you should think twice or even thrice before putting HCC or CA head of the pancreas as the first diagnosis? Okay, I'll wait for your answers. See, the answer is more say ethical. Answer is more ethical. I have given you a clue. It may not be best. No, I told the answer is more ethical. Empathy related or Aravind has answered. Treatable causes should be listed first. It's as simple as that. Once you are diagnosed with HCC, once you are diagnosed with carcinoma of the pancreas, prognosis is almost gone. There is no scope for treatment. Most cases, 9 out of 10, there is no scope for treatment. So try to bring in treatable cause first, irrespective of the description. You think if you can include a treatable cause there. So if you can bring in a treatable cause, which also matches with the history, then you can put it. Rest you try to bring down. Okay. Now, would you like to revise it now, Vignesh? Would you like to revise the order of DD? I'll give the opportunity to Vignesh again. Can you revise the DD? Can you revise the DD? See, there are very strong points even technically here. Okay. Because it's just 1 month of jaundice. Okay, now you have revised it as chronic infective hepatitis, NASH, and autoimmune. Again, does it fit into a criteria for chronicity? Does it fit into a criteria for chronicity? The definition of chronicity is a little complicated, but maybe I'll just try to bring it in. So what is the general definition? There is no approved definition. There are certain pointers you need to look for when you tell chronic. Okay, so I'll tell you the pointers. Symptoms should be there. If you look at hepatitis B, if you look at laboratory wise, the lack of clearance till about 6 months. Okay, some form of symptom should be there for a period of longer period, not definitely 1 month. 1 month will fit into the more of acute. Okay, can acute viral hepatitis have symptom for 1 month? Can acute viral hepatitis have symptom for 1 month? Can it have jaundice for 1 month? If so, what percentage? Just simple hepatitis B. Hepatitis B, can it have jaundice for 1 month? Without going ahead into a fulminant kind of a liver failure. So what percentage? What percentage? It's a complicated question. So 25 is a higher rate. See, around, if you look at published series, see why I am interested in that 1 month. See, when hepatitis B is having, when a patient diagnosed hepatitis B is having jaundice for 1 month, it has an implication in the management. Can you tell it? Then I'll come back to you why I asked that question. When a patient with hepatitis B has jaundice for 1 month, it has an implication in management. What is that implication? More chance of progression to chronic. Management. I agree. You're right. Something, one more. From the management. Investigation or treatment. That's what we mean by management. Okay, I'll give the answer. There is a role for antiviral. If the patient with hepatitis B is having symptom which is crossing 4 weeks, there is a role for entecavir. There are some centers which even use lamivudine, though we don't use lamivudine in patients with the chronic hepatitis B. We have stopped using it. In acute hepatitis, symptom more than 4 weeks, there is a role for antiviral. Okay, so which means that a proportion can actually go up somewhere around 2.5 to 5%. It's less than 5%, I would say. Anas has got the answer. I hope he got it from some data, not a guess. Okay. So okay, fine. So it still falls under a acute phase. If you talk about CMV or EBV, it falls around a subacute phase. CMV can actually produce it. Is this patient at risk for CMV hepatitis? Is this patient at risk for CMV hepatitis? Is your patient at risk for CMV hepatitis? Yes, it is immunocompromised. So patient at risk. EBV hepatitis is relatively rare. Okay. But CMV hepatitis, though the number is proportional less, it can still. So I think should you how you are telling it's NASH? Why you are bringing in NASH? Does the history fit into NASH? Does the history fit into NASH? Others can also contribute. Does the history fit into NASH? NASH has a more chronic progression. See, first look at the risk factor. This patient is on diabetes treatment for only 2 years. Okay. You mean NASH due to hypothyroid? That is relatively quite rare. Quite rare. NASH due to hypothyroid is quite rare. So let's not bring in NASH there, because generally NASH can be entertained in patients who have risk factor. For example, diabetic for a very long duration, who's on insulin, or duration which has crossed more than 10 years, or the symptom which is of a even more longer duration, like fatigue for a very long duration. Okay. So NASH is quite a premature. So I think I would put it across, since the duration is not long. I think the safer way will be to, you can put to acute or subacute hepatitis. That's a safer way, or possibly chronic. But I think I can stick to acute or subacute hepatitis will be a better differential diagnosis, because anyway subacute hepatitis B, everything is going to come in there. You can bring in acute, so you can tell that history is suggestive of acute to subacute hepatitis. I would like to give a differential diagnosis. Okay, so you can bring in hepatitis B there, and even hepatitis E. A proportion of them, they can have jaundice, which is there for a longer period of time, and maybe you can consider the possibility of CMV and HCV also. So you just keep it open and don't bring in definitely malignancy here. I don't think there is no pointer for malignancy in this case. And you can bring in autoimmune hepatitis. So again, subacute form of autoimmune hepatitis can also be brought in, because the patient has a very strong risk factor. In fact, if you look at published data, autoimmune thyroiditis people are one of the topmost people who are affected by autoimmune hepatitis. Hypothyroidism is a very common thing. Autoimmune hepatitis very frequently is associated with autoimmune thyroiditis, either in the acute phase or subacute phase, or in the resolution phase. Okay. So I think with this, I'll stop the history part discussion. So any doubts you have in the history part discussion? Any doubts? Mohammed Anas has put weight loss. Weight loss can happen in acute. Acute to subacute, you can have weight loss. It's quite well known. Any doubts you have in history before I go to the clinical examination? Okay. So these are any doubts also you can ask. Any clarification you want. One thing I think NASH I have clarified. NASH diabetes I have clarified. Weight loss also I have clarified. Any other doubts you have in the history level? At the history level? Okay. So I'll go to the clinical examination. So conscious oriented afebrile, mild pallor is there, icterus is present, no clubbing, cyanosis, pedal edema, lymphadenopathy. Okay. See, always elaborate the pulse properly. Don't go for any compromise there. Though it's an abdomen, you elaborate it properly. Blood pressure, no signs of liver failure. Okay. Inspection, flabby, flanks free. Again here, can one of you tell the proper description of inspection? Don't miss out on the description of inspection. As I told you, examination should be clear here. So what is missed in the inspection? A description should be clear. We have to give a proper description in inspection. So what is the first thing you will tell in inspection? Okay, I think I'll just correct it quickly. Maybe I'll give 2 minutes for you to tell the rectifications, others, then I'll correct the inspection. See, again and again, I'm actually repeating. Don't make basic errors which is allowed to be done by an undergraduate. Okay. Inspection, first thing you have to write is shape of the abdomen, or you can tell whether there is any distension. There are two ways you can tell. Either you can tell generally there is no defined shape, so you have to tell that is the abdomen is distended or not. By flabby, what do you mean? By flabby means what do you mean? Do you mean there is a generalized distension, or Vignesh, what is that you are meaning by? So first thing you have to tell that is there a generalized or focal distension. This is the first thing you have to obese abdomen. Okay. So then you tell it as it is generalized distension. So this is what you need to tell first. Okay. So is there a generalized or a focal distension? So this can be removed. Flabby should not, it's not a standard description we use, so that we'll remove. Okay, flanks are free. So this should be mentioned because distended flanks could indicate ascites, but even fat can produce a distended umbilicus. Sorry, distended flanks. Now coming to umbilicus. So umbilicus, you need to elaborate the position of the umbilicus. Position of the umbilicus. Is it inverted, everted, or flush with the abdomen? Abdomen. Is the umbilicus stretched? Okay. Then any discharges, any nodules, any dilated veins around. Okay. So umbilicus description is important. Position of, I mean umbilicus, description of umbilicus. Position of umbilicus, that is whether it is equidistant from is the description of umbilicus clear? Flesh with abdominal wall. Anand, I think your question is flesh with abdominal wall. Flesh with abdominal wall means it is neither inverted nor everted. It's just at the level of abdominal wall. That's what the meaning of flesh. Anand, is it clear? Okay. So umbilicus is fully elaborated. So now you will tell no dilated veins around the umbilicus. Okay, you have mentioned about umbilical hernia. Okay, that's correct. Small umbilical hernia. So umbilical hernia, you can put it once that's umbilical hernia. It's you cannot tell whether it is everted or not. So you will replace the inverted everted flesh with the abdominal wall. You will change it with the umbilical hernia. All quadrants move equally with respiration. Fine. Scar, you just elaborate the scar. Tell it as a linear scar. Subumbilical small linear scar, horizontal linear scar is seen. Describe the scar, and you can tell probably it is a tubectomy scar. Don't straight away tell it's a tubectomy scar. No dilated veins over anterior or back. Okay, so this is important. Then sinuses, hernial orifice free. You should mention about presence of striae. Striae. Okay, it can be a purple or it can be a white stripe. Okay. And please also include if there is any divarication of recti. Divarication of recti. Okay. So what is the relevance of this striae, divarication of recti? What is the relevance of back veins? These are all not relevant for this case, I agree. Not relevant for this case, but why it should be documented? Okay. So long-standing ascites. So divarication of recti, you are asking because you are looking at a long-standing abdominal distension. Striae, again stretch. Either a recent stretch or a recent reverting back. Okay, so when the patient lose weight also you can develop a striae. Previously stretched abdominal wall, that's a clue. Back veins. Back veins. What is the reason for back veins? Why is back veins important? Okay, back veins is for Budd-Chiari. Yes, it's for Budd-Chiari and also in IVC obstruction. Okay, that's a reason I've brought in back veins. Back veins, some people argue that it differentiates, but it can be either Budd-Chiari or IVC obstruction. Okay. Now, so you in inspection ensure that you elaborate on the umbilicus properly, the distension part properly, scars you have elaborated. Also, don't forget the divarication of recti, veins, hernial orifice, and also the any scrotal swelling. Okay, scrotal swelling should also be included there. Okay, now going ahead, is the elaboration of inspection clear? Is the elaboration of inspection clear? Okay, so now is there any doubt you have highlighted? Okay, so going to palpation. See, when you palpate the abdomen, what is the first thing you should document? What is the first thing you should document in palpation? It's not warmth or tenderness. Yes, put warmth or tenderness. No. Something extremely basic. This is why I repeatedly tell. See, first you need to be a good UG student. First, you should be a, I'm talking about description. Palpation. First thing what you elaborate in palpation. I'll just give 1 minute and I'll put the answer. First thing. No, you are not bringing in R. Vignesh is close to the answer again. Okay. So, palpation, you will put it as superficial palpation. Okay. Soft in all quadrants. Whether the abdomen is soft or not in all quadrants. This is a very, very important thing. Always remember this. Don't miss it. If you take any clinical book, palpation will start with superficial palpation. You cannot go and straight away palpate the liver or the spleen or anything else in the abdomen without doing a superficial. These are core basics. Reason I'm repeating it again and again because these are exactly the mistakes what we see when you do at the bedside and also when you document it in assessment. So superficial palpation documentation is mandatory and it's very, very important. And it will in fact give you a lot of help to navigate through the abdomen, to know what is really going on. Superficial palpation will give you a very. So then you soft in all quadrants, then you will tell not tender. Okay. And warmth actually you do not tell because abdomen will be little warm. Abdomen will be little warm. I think so. Don't talk about warmth or the abdomen. I don't think it's that relevant. So when fluid comes in, it becomes warm. Normal palpation also it can be warm. So warmth, I'm not really sure it's really relevant here. So definitely you have to tell whether it's soft in all the quadrants and it's not tender. And it is, if you tell it soft, it means that it is not rigid. Okay. So this I'm removing it. So next you are going ahead with the liver. Okay. So at a PG level, you describe the mass. Nothing wrong in telling it the liver, but preferably you tell that a mass is palpable in the right hypochondrium and you have to tell the dimension. So you have told about, so any corrections for liver palpation elaboration? Any corrections for liver palpation elaboration? Liver palpation elaboration. What should be corrected? He has written liver palpable 7 centimeter below the costal margin in the midclavicular line, not tender, smooth surface, firm in consistency, rounded margin. Okay. So corrections. What are the errors which should be corrected in this? What should be corrected? Moves with respiration. Something, see, any liver will move with respiration. Remember that. Even if it is a hard liver, it will move. A liver which is not moving with respiration is, I think I don't think it's possible. The diaphragm is functioning, liver will always move. Liver will never get fixed. So what is missing there? Okay, so preferably you will tell it as, you will start with as a mass palpable. I told you, mass palpable, dimension 7 centimeter below the which costal margin, right or left? You have to mention the right. Okay, so you tell it as a mass, tell it as a right costal margin in the right midclavicular line. Okay. Now, if you can get additional landmarks, please include it. Okay. Is it palpable in the epigastrium? Is it palpable in the epigastrium? Okay, if it is palpable, you have to give a better thing. Then is it palpable in the anterior axillary line? You understand? Landmark should be very clearly given. Okay, you have tell not tender, agree. Surface is you know the consistency before the surface. So the consistency should come here. This should be given the priority. Firm consistency, okay, smooth surface, rounded margin, and is it pulsatile or not? Okay, pulsatile or not? Okay, so you will tell about the extent of enlargement. Is it tender or not? If it is tender, you won't go above it. If it's tender, you won't be able to identify many things which you have told subsequent. So you can tell that if it's tender, it is tender. So I didn't go ahead and do a detailed liver examination. You can tell that. Then you have to tell about the surface, consistency, margins, and the whether it's pulsatile or not. So then he has elaborate. Spleen is not palpable, kidneys are not palpable. No free fluid, don't document it because it's a percussion finding. Okay, don't mention no free fluid because you cannot find it with palpation. Okay, so then you have told about the measurements and all. So basically, you are looking into the palpation of the organs only. So I think that you have elaborated. Percussion, you have told the liver thing, and don't tell the tidal percussion. It's not relevant for abdomen. It's not relevant for abdomen. Don't bring in tidal percussion there. So percussion, you just tell that whether it is it relevant, is it resonant in all areas? If not, which are all the areas? If not, where not resonant? If not, where not resonant? Any percussion tenderness. Okay, fine. So liver span, if you want, you can tell it. Auscultation, normal bowel sounds, no bruit. Again, you have to tell what bruit. No hepatic bruit or rub. And for spleen, if it's enlarged, you have to tell about the splenic rub. Otherwise, you have to tell that it is hepatic bruit. You have to document about renal bruit also. Okay, so renal bruit, though it may not be relevant, just remember these are the things commonly heard. We hear a renal bruit, we hear a hepatic bruit. Splenic rub is quite rare. Okay, so other systems you have written. Okay. So I think, did you understand the corrections in the examination? Corrections in the examination, whatever I have done, is it clear? Any doubts you can ask here. Is it clear? Okay. Fine. Now we'll go ahead with the differential diagnosis. So we have a patient. Now I'll give you the option now. Vignesh, do you want to revise the final diagnosis? Do you want to revise the final diagnosis? Do you want to revise the final diagnosis? Yes, can you try it? I'll give you some time. Think and finalize your final differential diagnosis. So it's a 1 month history of jaundice, 1 month history of upper right abdominal pain. Examination, you are having an enlarged liver, which is firm, non-tender. Now you have to think about the possibility of a differential diagnosis. Remembering the age also, you can try. granulomatous hepatitis, autoimmune hepatitis, CME hepatitis. Vignesh,
Yes,
granulomatous
sir.
hepatitis, autoimmune hepatitis, CME hepatitis. So why you think it is a granulomatous hepatitis? Can you justify why you have put granulomatous hepatitis? Acute presentation. See, by granulomatous hepatitis, jaundice. Okay. By granulomatous hepatitis, are you meaning it is because granulomatous hepatitis causes cholestatic jaundice? No. Classically, I'm telling. Classically, granulomatous hepatitis causes cholestatic. So clinically, telling a granulomatous may be difficult. Generally, no. In the absence of cholestatic features, putting granulomatous hepatitis may not be that correct. Clinically, you may be true. Laboratory wise, you may be true. But clinically, putting that may be a little difficult. Others, can you come in? Others, can you come in and give the alternative differential diagnosis? I'll come back to the DD. Others, can you try for alternative differential diagnosis? Others, are you trying? I'm not getting any answers. Senthil has given it as acute to subacute hepatitis, autoimmune or viral. Okay. Which you will prefer, Senthil? I agree with your differential diagnosis. Which you will prefer? We will give autoimmune viral. Okay. See, this is the age is little higher. Can autoimmune hepatitis occur at 50 or 60 years? Is it common? Autoimmune hepatitis? Yes, it's very common. See, the spectrum is actually emerging. It's emerging. It's emerging. Okay. So it's not common, but again, it's not uncommon. So you bring it down the list. Don't tell autoimmune at the first thing, though hypothyroidism. So I think we can stick to the same thing. You can tell acute to subacute hepatitis, possibly hepatitis B. Generally, hepatitis C presenting as jaundice at the onset is not relatively common. Okay. So I think we can bring down hepatitis C a little bit, but we will give priority to hepatitis B. You can also think about the possibility of CMV, quite common in this kind of a setup. Now, if it is CMV, I think I forgot to ask you in the history actually. If it is CMV, what are the extra hepatic symptoms you should have asked for? I think I left it out in the discussion in history actually. So what is that you shall? Okay, UVA, it is something more common. What do we see in which organ? Diarrhea, exactly. GIT. GIT is a GIT involved in the form of oral ulcers or in the form of esophagitis or in the form of colitis. Okay. So GIT involvement. So GIT involvement will put us more towards the possibility of a cytomegalovirus or a retinal involvement will put into a cytomegalovirus. Though in the outside HIV setting, CMV retinitis is not that common. You need to understand the epidemiology also. So in non-HIV setting, it's GIT is more commonly affected rather than the eye. Okay. So I think we can stick to the final diagnosis as acute to subacute hepatitis. Like to give a differential diagnosis for that HBV, CMV, you can bring it in. NASH definitely no here, and maybe autoimmune you can put down as a center because patient is a hypothyroid. We can get autoimmune. NASH plus or minus. You can bring in NASH or you can put what I would say is a pre-existing liver involvement which has got worsened. Okay, a secondary involvement. So you can bring in NASH as a maybe a third. I'm not sure whether you can bring in NASH or you can just leave it as a subacute, acute to subacute. Okay, so you can put it as a DD there. You can leave it there. Is a differential diagnosis clear till now? I'll just ask few questions and we can close the class. So is the differential diagnosis clear? It can be flexible. See, the opinions may vary. I may look at a particular set of differential diagnosis. Another assessor may think that you can bring in NASH also into it. You can also bring in other differential diagnosis like sarcoidosis. That's but generally, definitely HCC you cannot bring in. See, what are the findings which is required to tell it's HCC? When you tell HCC, there are certain findings which should be present. Without that, they're telling HCC is not that correct, at least clinically. What are the physical findings which you expect in a HCC examination? Very good. Hepatic bruit. So it should be a hard liver, or at least some areas which are hard. A combination of firm in certain areas, a combination of hard in certain area, presence of hepatic bruit. So this is relatively expected. Mass is not smooth, surface is irregular. These are some things which is required before you tell. So definitely you cannot bring in hepatocellular carcinoma with this finding. So I am taking out hepatocellular carcinoma. NASH plus or minus, it all depends on how you discuss. I cannot rule out NASH definitely, but definitely you can tell it's a, don't tell it's viral. You can tell acute to subacute. Hepatitis, if you want, you can tell subacute alone and you give a differential diagnosis for the subacute. Okay. Now going into the investigation. So we'll go back to Vignesh. Now, given this differential diagnosis, we are having a differential diagnosis of acute to subacute hepatitis. Before we think about chronic hepatitis, we'll first look at acute to subacute hepatitis. What are the investigations you will ask? What investigations you will ask? Okay. Tell me, it's obvious you will ask for LFT, there is no doubt in it. Tell me the diagnostic investigation. Diagnostic things which may tell you what is the cause. Ultrasound abdomen, agreed. SGOT. I'm asking you a diagnostic which clinches the diagnosis. Diagnostic investigation. No, don't use viral markers. Tell me clearly what is that you want. Hepatitis B serology means what? Be precise. Okay, you will ask for HbSAg. Okay, so we will ask the HbSAg. First level, you will ask for HbSAg. Of course, you will ask for anti-HbC. Okay. Now, what clues in the LFT? What clues in the LFT will make you think that it is probably chronic? What clues in the LFT will make you think that it is probably chronic? Okay, one, hypoalbuminemia, agreed. Reversal of AG, okay. Hypergamma-globulinemia, agreed. Low albumin, agreed. High globulin, agreed. Anything else? ALT levels elevated. Okay. Reversal of AST and ALT ratio, to some extent I agree, but not for all. Okay. I asked you what will make you think it is chronic. The answer is a high bilirubin with a 2 to 3-fold elevation in AST and ALT and not very highly elevated alkaline phosphatase. That is what that's the answer I wanted. Okay. Disproportionately elevated bilirubin compared to the AST and ALT. And alkaline phosphatase not very highly elevated. This is what I will look at for a hepatocellular, chronic hepatocellular involvement. This is a combination what I will actually look for. Okay. So what is the LFT pattern you will get in autoimmune hepatitis? What is the LFT pattern you will get in autoimmune hepatitis? Is there any characteristic LFT pattern you will get in autoimmune hepatitis? Okay, I think I'll give you some time on this. I'll give you the question alone. Aditya has given the answer as predominant ALT elevation. No, please read. There is some ratios. I'll give you the question. Please today with this case as a template, read the following things. Spectrum of LFT pattern in autoimmune hepatitis. ALT, AST more than 1.5. No, I'll give you time. Please read it. I'll give you time. Please read it. These are, you need to read elaborately on that. Spectrum of LFT pattern in hepatitis B, chronic hepatitis B, chronic hepatitis C, autoimmune hepatitis, and NASH. Four disorders. Read the spectrum, because here LFT, as you told, will give you a clue on how to go about. Okay. What is the problem with evaluation of autoimmune hepatitis? What is the problem of evaluation of autoimmune hepatitis? What is the practical problem we face? Evaluation of autoimmune hepatitis. Cost. Cost is the problem. Okay. Mimickers of autoimmune hepatitis come. Cost is the problem. I need to do what has to be done. If you are going to evaluate for autoimmune hepatitis, I will give you that you can do only 3 antibodies. Only 3 antibodies. What you will do? 3 antibodies you can do. What are the 3 antibodies? I want 3 answers. 3 answers. Most of you are given only 1. Okay, I'll give you answers. So this is again, you please read. What are the 3 first-line antibodies you will ask in autoimmune hepatitis? See, the cost of autoimmune hepatitis panel is close to 20,000. If you do 4th generation assays, it costs 25,000. So what is the 3 first-line antibodies you will do before you evaluate for autoimmune hepatitis? Okay, so I think in this case you should learn the evaluation of subacute hepatitis. Okay, acute and subacute. So how is acute hepatitis diagnosed? How is acute hepatitis A diagnosed? How is acute hepatitis E diagnosed? And you know, hepatitis C doesn't present with acute hepatitis. It's more of a chronic. So then subacute. Subacute, different causes we discussed. How is the LFT pattern? What is the test you do? Inclusive of viral. What is the test you will do for CMV? What is the test you will do for CMV? Cytomegalovirus. What is the test you do? Vignesh has answered CMV DNA. Where? Which sample? Which sample you will send? Which sample? Okay. Any other answers? Liver biopsy? No. Okay. Again, that is so. I've given you some questions. I think I'll close with this. I've given you adequate questions to read. So read about the initial 2 things, presenting symptoms I told. So read about the presenting symptoms, presenting signs of all these disorders, and the initial evaluation of hepatitis, acute hepatitis A, acute hepatitis E, acute hepatitis B. Okay, 3 things. Then you read about evaluation of chronic hepatitis B, chronic hepatitis C, CMV hepatitis, autoimmune hepatitis. So I've given you around 6 evaluation algorithm. Please read about it. I'll put a quiz on this. Okay, so based on this case, I'll put a quiz in Academy. I think we'll see how much you are able to contribute. So we'll try to read focused in this. So any doubts? Any doubts? Any doubts? I think it should be difficult for most of you. You have attended the work in the morning and taking up the classes. So any doubts? If no doubts, I will. Any doubts? Aditya, I'm not getting your question clearly. If autoimmune hepatitis considered, should PBC features brought in? See, basically the primary biliary cirrhosis is quite uncommon. Should PBC features brought in? Not necessary. See, primary biliary cirrhosis, if you go through, if you look at the prevalence data in India, autoimmune hepatitis is quite highly prevalent compared to primary biliary cirrhosis. It's a rare diagnosis. So at your level, at the differential diagnosis level, no need to bring in primary biliary cirrhosis. No need to bring in primary biliary cirrhosis. Is it clear, Aditya? Okay. So